Hi and welcome back. You may remember in February 2021 I uploaded a video talking about the limitations of the BMI formula. I recently read a piece that dived deeper into the BMI formula and how when it's used incorrectly it could misdiagnose people and not allow them the treatment, the life-saving treatment that they actually need. Enough waffling off me, let's jump into the presentation and see what this new deeper dive into the flawed BMI formula has got to offer.
This is a review of a piece I read that was penned by Julie Apple in Kaiser Health News. It dives deeper into the limitations of the BMI formula and how it's being misused by different organisations. Then she highlights how this misuse is stopping some people from getting the life-saving treatment that they really need. And there's links in the description below to the studies and the articles I used to put this presentation together. People who seek medical treatment for obesity and or an eating disorder do so with the hope their health plan will pay for some of it. But whether or not it's covered often comes down to a standard that was invented almost 200 years ago by a Belgian mathematician and astronomer as part of his quest to use statistics to define the average man. Yes, the average man. So at the time, I'm safely assuming a white heterosexual male, no women and certainly no other ethnicities. That work, done in the 1830s by Adolphe Quintelet, appealed to life insurance companies, which created ideal weight tables after the turn of the century. By the 1970s and 1980s, the measurement, now dubbed the body mass index, was adopted to screen for and to track obesity. Now it's everywhere, using an equation, essentially a ratio of mass to height, to categorize patients as either overweight or underweight, or as what is deemed a healthy weight. Many critics say that BMI was never meant as a health or lifestyle diagnostic tool. Dr. Fatima Stanford, an obesity medicine specialist and the equity director of the Endocrine Division at Massachusetts General Hospital, put it succinctly when she said, "BMI does not come from science or medicine." Dr. Stanford and other experts have openly stated that BMI can be useful in tracking population-wide weight trends, but it falls short by failing to account for differences among the sexes and ethnic groups, and it can target some people, including athletes, as overweight or obese because it does not distinguish between muscle mass and fat. Unfortunately, BMI has become the go-to tool that determines who, when it comes to health consequences, is most at risk and who qualifies for often expensive treatments. Without using BMI as the principal tool, many studies have shown that people who are overweight or obese are at greater risk for a host of health problems, including diabetes, liver issues, osteoarthritis, high blood pressure, sleep apnea, etc. This is beyond debate. The BMI measure is commonly included in the prescribing of weight loss drugs. Some of the newest and most effective drugs, such as Wegovy, limit use to patients who have a BMI of 30 or higher, the BMI obesity threshold, or the lower level of 27, but then only if the patient has at least one other weight-related medical condition, such as diabetes. Doctors can prescribe medications to patients who don't meet the BMI requirements, but insurance companies in most cases will then not cover that cost. While most insurers, including Medicare in the USA, cover some forms of bariatric surgery for weight loss, they may require a patient to have a BMI of at least 35, along with other health conditions such as high blood pressure or diabetes to even qualify. With medications, it can become even trickier. Medicare, for example, does not cover most prescription weight loss drugs, although it will cover behavioral health treatments and obesity screening. Dr. Stanford says it's very frustrating because everything we do in obesity medicine is based on these BMI cutoffs. Serena Nangia, Communications Director for Project HEAL, a non-profit that helps patients get treatment, whether they are uninsured or have been denied care through their health plan, said, for eating disorders, insurers often use BMI to make coverage decisions and can limit treatment to only those who rank as underweight, missing others who need help. Serena went on to say, because there's such a focus on BMI numbers, we are missing people who could have gotten help earlier, even if they are at a medium BMI. If they are not underweight, they are not taken seriously and their behaviours are overlooked. Dr. Stanford said she too often battles insurance companies over who qualifies for overweight treatment based on BMI definitions, especially some of the newer, pricier weight loss medications which can cost more than $1,500 a month. She stated, I've had patients doing well on medication and their BMI gets below a certain level and then the insurance company wants to take them off the medication. And although she challenges all these decisions, she said, sometimes I win, sometimes I lose. While possibly useful as a screening tool, BMI alone is not a good arbiter of health, so says Dr. Stanford and many other experts. The health of a person with a 29 BMI might be worse than one with a 50. If that person with the 29 has high cholesterol, diabetes, sleep apnea, or a laundry list of things, while the person with 50 just has high blood pressure. Which one is sicker? I would say the person with more metabolic disease. Additionally, the experts say that BMI can overestimate obesity for tall people and underestimate it for the short ones, and it does not account for gender and ethnic differences. Case in point, Dr. Stanford points out that black women who have a BMI between 31 and 33 tend to have a better overall health status, even at the above 30 level, than other women and men. Meanwhile, several studies, including the long-running Nurses' Health Study, found that Asian people are at greater risk of developing diabetes as they gain weight, compared with white people and other certain ethnic groups. As a result, countries such as China and Japan have set lower BMI, overweight and obesity thresholds for people with Asian descent. Experts generally agree that BMI should not be the only measure to assess a patient's health and weight. David Creel, a psychologist, a registered dietitian and the director of exercise physiology at the Bariatric and Metabolic Institute of Cleveland Clinic, said, it, talking about BMI, does have limitations. It doesn't tell us anything about the difference between muscle and fat weight. He noted many athletes might score in the overweight category or even land in the obesity range due to muscle bulk. Instead of relying on BMI, physicians and patients should consider other factors in the weight equation, one of them being weight distribution. Studies have shown health risks increase if a person carries excess weight in their midsection. David Creel stated, if someone has thick legs and most of their weight is in the lower body, it's not nearly as harmful as if they have it around their midsection, especially their organs. Dr. Stanford agrees, saying midsection weight is a much better proxy for health than BMI alone, with the potential for developing conditions like fatty liver disease or diabetes directly correlated with weight size. Patients and their doctors can use a simple tool to assess this risk, that is the measuring tape. Measure just above the hip bone. Women should stay at 35 inches or less, and men should be at 40 inches or less. New ways to define and diagnose obesity are in the works, including a panel of international experts convened by the prestigious Lancet Commission. Dr. Stanford is a member of this group. Any new criteria ultimately approved will not only help inform physicians and patients, but also affect insurance coverage and public health interventions. Dr. Stanford has also studied a way to recalibrate BMI to reflect gender and ethnic differences. It incorporates various groups' risk factors for conditions such as diabetes, high blood pressure, and high cholesterol. Based on her research, she said the BMI cutoff would trend lower for men as well as Hispanic and white women and would shift to slightly higher cutoffs for black women. There's no plan to eliminate BMI, but to devise supporting strategies to further evaluate the health associated with weight status.
Well, I hope you found that interesting or informative, hopefully both. I will post a link in the description below to my first BMI video that covers all the reasons that it's outdated and flawed, but also a number of different ways that you can check to see if you are in fact overweight or obese. Let me know in the comments below, do you believe that the BMI formula is indeed outdated and flawed? And let me know in the comments below what metric you use to decide whether or not you're obese or in fact overweight.